So thanks for the opportunity to talk about the RSA surgical technique. My disclosures are relevant that I do consult for Stryker's shoulder arthroplasty. And that for me, when you have retroversion greater than 30 degrees, this is when I consider doing a RSA, whether it's retroversion or inclination in that respect. And a good example of this is this 74-year-old, a dysplastic glenoid retroversion of 50 degrees. You can see the significant posterior subluxation. You can see the retroversion on both the CT and the MRI and the significant glenoid deformity. In this case, once again, the retroversion is 50 degrees, posterior subluxation of 96%. In this planning software, we're able to plan out our bone graft, plan out our ultimate correction. After doing a basic deltoid pectoral approach and tagging the biceps, opening up the bicipital interval, at this point, we will tag the subscapularis, as you can see here. I like to use a knife when I take down the initial part of the subscapularis off the lesser tuberosity. And then I use a bovie just below the lesser tuberosity. So then exposing the humeral head, I do a small cut just to get rid of some of the sclerotic bone. And then I will start the alignment for the RSA. So this is the reamer for the RSA. You can see we're reaming out a nice significant component of it. Then we'll ream out the middle of it. And you can see we've already basically prepped this sort of wedge of the RSA. We then will confirm our humeral head cut. I like to use just a referencing of the extramedullary guide, but I do freehand these cuts. And you can see where we are getting a really nice aggressive humeral head cut. You can see the wedge graft that we've been able to harvest at that point. Then we'll prepare, and in this case, especially with RSAs, I do like the inlay. It allows you to kind of medialize the humeral component. So you'll ream and then eventually broach for it to protect the humerus, and then you can move on to the glenoid. So the glenoid, I'd use a large posterior glenoid retractor, a superior glenoid retractor, as well as an anterior glenoid retractor. So I'm releasing the subscapularis, mobilizing the capsule. At this point, we're also releasing some of this labrum and then the guide pin. The guide pin, really important to place it just anterior and just inferior to that center point. You can use this right angle to make sure that you're on the anterior neck of the glenoid, make sure you're matching your ultimate version. This reamer is a nice reamer. So you have different options of 30 degrees, of 35, 25, or 15. I start at 35 and then ream down to 25 to help correct some of the version and allow me to have a little bit more accurate graft placement. I then use this burr to kind of help touch up any areas that the reamer didn't touch, and then I'll drill for my central post. And then we'll prepare the graft itself. So you can see here, we're using a graft. We're using a burr to kind of touch up the graft. I like to create this sort of wedge, and I've pre-measured on the templating software how big the graft needs to be and how big my wedge needs to be. So you can see here, we did about a 16 millimeter graft by about 2. So then I'm going to place the wedge, or place the central post, and then have the wedge kind of pointing posteriorly. You can see there you have a pretty nice graft in place with the central post well into the native glenoid. I then will place the 2 non-locking screws, and then I'll place the 2 lockers to kind of lock everything in place, as you can kind of see here. And then to measure for the actual glenosphere. And the way I do this is I use these paddles that allow me to measure the space between the metaphysis and the base plate, and allows me to estimate what size glenosphere I'm actually able to accommodate. I then will place the glenosphere and impact it in place, and then I can turn my attention back to the humerus. I first start with a trial. Once I'm happy with the ultimate size and tension of the humerus, I then will drill for my subscapularis. As you can see here, I like to use some transosseous stitches. Then you can place your inlay component and get a really nice press fit, place your polyethylene, and then ultimately reduce it in place. Then you will repair your subscapularis, and you can see the ultimate construct with that nice bone graft kind of posteriorly. So this is what this patient did. You can see pretty nice overall graft incorporation on the image on the right. And with this kind of mimics what we found. We looked at patients who had 24 RSAs for retroversion greater than 30 degrees, had basically a 96% complete graft incorporation of follow-up of 3 years. We did have one revision, but overall patients seemed to incorporate this technique very well. So thank you very much for your time.